Assalamualaikum and a very good afternoon to all of you. Thank you for joining us for today's CME. I am happy to see there's a lot of doctors from Hospital Tunku and Jempol also joining the CME session. So today we will be talking about the integrating nephrology and palliative care setting. So we are really blessed that Dr. Rafidah would give her time to talk about introduction regarding integrating nephrology and palliative care. Actually, I don't know whether I should introduce Dr. Rafidah or not, but most of you, I think, know her already. She's a consultant physician and nephrologist, Hospital Tunku Ampuan Najihah, and chair of Renal Palliative Care Committee, MOH service. So from here, you know that actually she's really good in palliative care, dialysis, palliative care, nephrology. So without further ado, I would like to give the mic to the Dr. Rafidah for her talk. Thank you.
Okay, thank you so much, for the kind introduction. Okay, let me get my slides. I tak adalah famous sangat macam tu. Maybe I'll just introduce myself again. Thank you again for everyone for joining me this afternoon, because I think this is a very, very important topic for everyone to know. The reason why I say that is because, this is the program that we have today. I'm going to talk about 30-35 minutes macam tu. I'm more than happy to answer questions, because I think there are a lot of practical questions that you may want to ask pertaining to this topic. Okay, the reason why I really like palliative care is because you can see here, this is my colleagues or college mates. I did a master's in, as many would have known, I'm a nephrologist. I've been a nephrologist since 200, tak ingat lah, 204 I think. But I think after many years of work, I felt that, there's something missing. Therefore, I decided to do master's in palliative care. Master's was mainly research based, but it was good because in this picture there are so many people across all specialty. So basically they were what do you call that? Wait, let me get my laser pointer kejap. Okay. They were neurologists, they were palliative care physicians, they were GPs, they were anesthetists, they were pharmacists, occupational therapists, physiotherapists, cardiologists up here from Canada, for example. So there's so many people actually wanting to learn about palliative care, and actually we learn a lot from each other. And I realized that this is actually, I hope to impress upon you, this is actually the way forward. So the outline of my talk today will be a little bit of introduction, a little bit about general palliative care, its definition, and what it is in nephrology, and how to apply and integrate into our clinical practice. Okay, so I think I would not have to impress you a lot anymore by saying nephrology patients are complex. They once you have a patient on dialysis, they have basically a life-threatening illness. Yeah, and a lot of patients have a lot of symptoms actually. And our patients, all renal patients actually throughout the nephrology care will need to have an incorporation of palliative care principles. I hope this is the concept I'm going to introduce today. And over the past decade, there's a lot of literature and research going on into actually investigating nephrology and palliative care and its outcomes. It's normal, like doing a lot of things, but like intervention and all that, but we are actually looking into a lot of more to the ground issues, like, how do we do shared decision making? How do we manage patients on non-dialysis? And how do we, address patients, families, how do we educate and how do we empower our patients? A lot of people actually think that no dialysis is no care. That's not right. I hope you would understand by the end of the talk that no dialysis is still a lot of care and compassion that we can actually deliver to the patients. So a lot of people actually equate palliative care to sort of cancer. This is, over the years, over the decades, it has changed. Palliative care is no more just for terminal cancers, right? It has now been incorporated into management of chronic disease, those with limited life prognosis. Some, whether it's actually renal disease, COAD, advanced heart failure, dementia, all sorts of things. We're dealing with this, and all these patients actually need a lot of palliative care. So let's go back to the actual definition of palliative care. This is the WHO definition. It is defined. I think this is very important for you to understand what it is so that we could practice it. It is defined as an approach which improves quality of life of patients and their families when they face life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment, and we treat the pain and other problems like physical, psychosocial, and spiritual. Dame Cecilia Saunders is actually the name of my institute in King's College. She was initially was a nurse, and she became a physician, and she was the first person who actually opened the Institute of Learning, and she coined the concept of total pain. Yeah? Pain is not just physical symptoms. It incorporates everything else as well, psychosocial, social, and physiological. So let's dissect the meaning again. So palliative care is actually provides pain, relief of pain and other symptoms. And it is accepting the dying is actually a normal process. It does not intend to hasten or postpone death. It integrates into the psychological and spiritual aspects of our patient care. Actually, when you ask the patient's home situation, you just talk nicely to the patient. You're already practicing palliative care, and we offer a support system to the patients, live as actively as possible or as acceptable as possible until their death. We offer a support system to the family as well, to cope with the illness and after that, when the patient dies. And we use a team approach, to address the needs of the patients and their families, including bereavement after death. We counsel them if indicated, and we hope to enhance the quality of life, and it is also applicable in the early course of illness in conjunction with other therapies, not just stage 4 cancers, but actually there are evidence saying that if you actually start palliative care early, then it's actually a much better, a lot of benefits there. And if you look at, this is a global scale, if you look at the Global Atlas, the Lancet Commission and all the rest of it, all our patients, masyarakat dunia lah, a lot of people in this world is actually experiencing serious health suffering. And if you look at it, it's close to half of the total death. And a lot of patients are actually living in low middle income country. So a lot of people don't realize that Malaysia is actually high middle income. On the contrary, that we see left and right, but we are classified as high middle income country. So a lot of these patients are actually living in a low and middle income countries, high and low middle income countries. And a lot of them, it's something that if you work in general medicine, it's something that you see every day. Patients dying from non-communicable disease, and it's 90% of the burden of end of life in palliative care. And this recent publication by somebody who I know from King's College estimated, towards 2060, there will be a lot more patients dying with serious health suffering. And a lot of patients are elderly, of course, cancer deaths, and also dementia is another group that we need to look at. So this is the graph here, and it shows definitely what I mentioned just now. A lot of patients are cancer, and this is the year. So this is number of deaths. This is 2060, and now 2010, 2020, 2030, and so on. So the number of deaths and sufferings are more. This is upper middle income country where Malaysia lies in. It'll be a lot worse in cancer, of course. And cardiovascular, I mentioned, dementia, and renal, if you look at it, it's down there, but it's there. Not even halfway, but it's, first top 7, 8. And if you look at the projection of palliative care needs, this is published recently, is the numbers from Malaysia. And it shows that the needs of palliative care has actually grown, and it's something that we cannot catch. If you actually ask or get or hope the palliative care physicians to do everything, I don't think we're going to reach at all. So saying that, we've had a survey performed in Malaysia, I think maybe it's 2016. The publication, this book assessment, estimated that only 8.3% of patients in Malaysia are receiving the palliative care when they need it. So this is actually very sad, because we're not really giving proper, palliative care to our patients that actually need it. But saying that, it's very interesting. If you look at the world map, Malaysia is actually one of the advanced countries in the world where we are approaching advanced integration here. I think primary integration level 4A. So the ones at yang merah tu is actually not known to have, then subsequently 4B is the best lah. Of course, the first world countries are the best ones. But interestingly, Malaysia is 4A. So we are actually not too bad. But then we are bad, but we're not too bad. So, we have to pat ourselves in the back as well lah. So let's go back to renal, go back to actual definition. I need to correct you with the definition first. Just to give an overview before that, what we're dealing with. We're dealing with, many renal failure patients. Yeah, chronic kidney disease in Malaysia, the prevalence is has gone up from 9% to 15.5%. That was published last year, and this is serious. So we have a lot of patients with CKD and a lot of patients with risk factors. We have to spend a lot of time to prevent this. Okay, of course, when we have kidney disease, patients will progress to end-stage kidney disease, which is obviously stage 5. And these patients, these are the patients you encounter. I think there's no way a nephrologist could manage all the CKDs, 15% of 36 million populations. In Malaysia, it's impossible. If the world is 276 million, it's completely impossible. But when they reach end-stage kidney disease, there are various options. As you probably realize that dialysis is the main ones. Hemodialysis is 90% in the country, which we're trying to get away from. We're trying to promote more palliative dialysis. And of course, transplantation is the only permanent treatment, right? Any dialysis is actually temporary. And comprehensive conservative care, which is a non-dialysis therapy as well, is also part of treatment. Therefore, I would urge to impress everyone, not giving dialysis is still treatment, right? So those are the patients. Not everybody can access some sort of treatment of end-stage kidney disease in the world. So it is a bit sad state of health. So again, go back to definition. We call it end-stage ESKD, end-stage kidney disease. So those patients who actually have late-stage CKD and when they're on some sort of renal replacement therapy. Something called supportive care. Supportive care, this is for all CKDs actually. Supportive care is we give them supportive care based on the palliative care principles I showed you just now. Yeah, where we actually focus on patients and families, focus on prevention and relief of suffering, and all the 4 aspects that I talked to you about: the physical pain, psychosocial pain, spiritual pain, and emotional pain. Okay, so that's supportive care. So basically, all patients of CKD or end stage will need supportive care. Yeah, when we go to conservative care, it's actually we have non-dialysis treatment, right? So it's either whether it's medically unfit or patient chose to be or whatever it is. But whatever it is, conservative care is actually non-dialysis therapy, right? So it is one of the option of treatment of renal disease. Yeah. And if we look at our patient statistics, we look at the palliative care needs. Palliative care needs is, of course, the symptoms that we're talking about. There's so many of our end-stage kidney disease patients have got a lot of symptoms. Actually, a lot of us try not to talk about this because when patients say you're tired, you're fatigued, we're like, sorry, Pakcik, can't do very much, this is kidney disease and all that. But a lot of us actually run away from talking about this, and because we don't know how to address it, right? But it's good to try asking, and sometimes just talking would help. Yeah. So just to show you in this slide that all our kidney, this is end-stage kidney disease patients, they have a lot of symptoms. They have a lot of sufferings. Okay. So let's talk about reality in nephrology. I think we work in Malaysia. I would say this is a statistics. This is a publication in Medical Journal of Malaysia, and I think what's happening in Sabah looks a bit better than what we're experiencing here, to be honest. You have to remember those patients who actually do not prepare for dialysis, they are crash landing. They have a lot poorer survival. That one we know, right? And this is where our patients lie, unfortunately. They have seen us, but they don't want dialysis for whatever reason. And then once they need dialysis, they come in so unprepared. We call it crash landers. This is very common. I think everybody, literally in Malaysia, if you actually ask to do dialysis, you never want to do dialysis. So this constitutes 66%. I would say this is quite good for Sabah, to be honest. In my practice, it's probably, a lot more than that unprepared, But anyway, if there are also patients, this is in Sabah again, 1 in 4 actually prepared. That's very interesting. So our patients belong to this group, and I think very difficult for us to change because nobody in Malaysia wants dialysis. I mean, fair lah. I'm not going to argue with them with that notion. Nobody, I always say, if patients want coming at my door wanting dialysis, I said something wrong with you. So I think it's the way we counsel as well need to improve. Okay, so let's talk about sort of a journey of kidney disease patients. Okay, so we have CKD stage 5. I mentioned just now the dialysis option, palliative dialysis and hemodialysis, and transplant is the best option, of course, and also the non-dialysis option. But there is also this group where they delay commencing dialysis and unprepared at initiation, right? So they just don't want dialysis, until they're very late. This is very common. I wouldn't call them in this category because they are the patients who actually will benefit dialysis, but they just refuse. So I wouldn't give them non-dialysis treatment because I think different. I would urge everybody to separate this group. Some other they don't want dialysis at all until they die, or they don't want dialysis until they are very late. So I think it's very important for you to know which ones the patients, the category the patient is in. Whatever it is, whatever said and done, this is a journey. I always tell my patients, it's a journey you and I take together, and every single step of the way, we need to give some sort of palliative care and some sort of supportive care for all our patients in all categories. Yeah, and those patients who don't do well, there is an option of withdrawal of therapy. I think, especially in this COVID era, if the patient is already doing unwell, I wouldn't ventilate the patient. I would literally withdraw. I mean, I've done that on a regular basis. In fact, literally on a daily basis over the last week or so. Okay, so withdrawal of dialysis in Malaysia is probably something that people think, can I do this? How do I do this? Is it right? So it's something that you sometimes play with your own self as a doctor. Am I doing it correctly? Am I doing it, right? This is, ethical or not ethical, but actually withdrawal of dialysis is the major cause of death in the first world countries. So it's not really wrong. It's not wrong actually, yeah. And decision to withdraw is not very simple. It's not that you just say withdraw and walk off. You have to decide with the patient and with the nephrologist in full consultation with relatives and carers and the other members of the team. So it's very difficult, especially in this COVID era where the family may not be with the patient. You have to do it, video screen, video Zoom, all sorts of things that makes it challenging. But I think it's acceptable. This practice is acceptable because if you continue dialysis in those kind of patients, it will only make them suffer even more. All right, if you actually withdraw dialysis, somebody who's on regular dialysis, you withdraw, the survival time is between 7 to 9 days. Okay, so this is my own practice. This is in writing when I was in Temerloh. I think a lot of people know that I left Temerloh early last year. Not even a year, I'm in Putrajaya. So a lot of patients, I think this is the same everywhere. Everybody start, in Malaysia, they start very late. When in Temerloh, it was close to 7 mil, less than 7 mil GFR, they start dialysis. And a lot of patients, even though these are the patients who I personally counsel in our dialysis preparatory clinic. So a lot of patients, when you counsel, a lot of them, yes, mine is 1 in 5 is undecided, right? 1 in 5 is undecided. And some really accept conservative care. These are the patients who actually I feel I share the decision with them. Whatever we do, we have to have a shared decision making. We share the decision with the patient. So this is, undecidedly, basically, I never share the decision with them. So they say don't want, but I say you should. So it's very difficult in this kind of situation. I think I'm sure everybody experience this regularly. And so therefore, my personal view in Malaysia, per se, we should have a 5th option. Okay, transplant, PD, HD, conservative, and those young undecided, or that we don't share their decision, right? They just don't want it until it's very late. So these are the patients you have to separate between those ones yang truly not for dialysis. It's difficult to counsel or manage this patient. Whatever it is, they're still our patient. We have to still manage them because they will still come back to you, like it or not. Okay, so these are some of the patients that will benefit from intensive palliative care. Those patients who actually forgo dialysis ataupun don't want to do dialysis, they will need a lot of conservative care, a lot of palliative care support. Those who begin dialysis, okay, but then they got worse. They get into hospital admission regularly or every other month, and the health deteriorates. The disease trajectory just gets worse. So it gets very iller and iller by the weeks, by the months. And those who are just poor candidates, dialysis may be offered, but prognosis is very poor. So if they go on dialysis, they have a lot of symptoms. We also need to manage them. Okay, this is the conceptual framework for supportive care. As I mentioned just now, every CKD deserves some sort of supportive care or palliative care throughout the journey of the disease. Yeah, but towards the end, the need for palliative care is more intensive, right? The initial part may be a little bit of, psychosocial support, ask them, oh, how are you? How's your second wife, third wife, whatever, So those are actually already, supporting them psychosocially as well. So, but towards the end, there's a lot of things that we need to support, and this is when the need escalates and where we probably will need to refer to proper palliative care physicians for help. Okay, I think a lot of patients, if you look at this disease trajectory, stage 5 CKD, we don't know how they go. Some of them stay very well until very long. I've had one of the patients here in Putrajaya. We managed, I think creatinine was 1,800 maybe 9 months ago, and she's still living. She refused dialysis, which I think fair. She has her own reason because her late husband, she's only 60 odd, but the late husband died of, the late husband was on dialysis for 5 years, and she was watching him suffer and struggle. Therefore, she opted not for dialysis, which we respected her decision. And about 9 months down the line, she's still alive. Yeah. So let's talk about application and integration into clinical practice. So I mentioned again, time and time again, it's very important to have early palliative care consultation, but it's not possible to have palliative care physicians managing this. So this is where nephrology or palliative care, consultation or palliative care integration comes into the standard nephrology care. So we as nephrologists or in fact, when Iskandar becomes a cardiologist, as a cardiologist, we could start integrating palliative care principles early in the disease. Yeah. So these are the aspects that we have to aim. When we instill all this, we get all these benefits. Yeah, higher patient satisfaction care, less days spent in the hospital, improved symptoms, and patients family are more happy with your care and all the rest of it. I think we need to look at integrating palliative care principles into any standard medical subspecialty care. So again, supportive care for end-stage kidney disease is actually a very important concept. And again, this is, I think, is something that I showed you just now, roughly, end-stage kidney disease, all these options. And supportive care throughout the disease, this is in green here, throughout the disease. But if you look at this, it's very interesting because in high-income countries, the green, mainly the supportive or palliative care is quite good in the high-income countries. We are not very good at that in middle income. We are actually just dialyzing everybody, but not really talking about palliative care. Of course, in low-income setting, they don't even get to have dialysis, so that's even worse, of course. But we should also heighten our efforts in prevention. Yeah. Okay, let's show you a hypothetical patient journey of a kidney disease patient. So imagine if towards the end they are about to die, suddenly I refer to palliative care physician or somebody else to manage their symptoms. I think it's not fair for the patient, yeah, because we as nephrologists, we manage the patient from the beginning, from the CKD, from whatever preparation for dialysis. We know what's happening throughout the years, and all the rest of it. So it doesn't, towards the end dia nak pergi, kita pergi pass kat orang lain. I think that to me is not really right lah. And I think we as nephrologists should be able to manage the patient in its entirety, the whole patient journey. So once you embark on a CKD journey, we should embark together. Yeah. So imagine again if we don't integrate. So there will be a lot of tensions between understanding. Suddenly is somebody else coming. And somebody else talking about dialysis, for example, say palliative care physician talking about dialysis and all that. So it's become very, very difficult, and there will be a sense of dichotomy between life prolonging intervention. So a lot of people, if they come in later, they don't understand what are the complications of dialysis or the rest of it. So it is advisable to integrate palliative care principles into the day-to-day nephrology care. How is it to be done? It's very simple actually. You have to have a little bit of able to communicate with the patient and the family, and you listen to them. Yeah, that's the first skill. And second skill is actually to elicit the goals of care of treatment. Yeah, goals of care. What do they want? You know, what exactly do they want? So usually all my hemodialysis patients, I always talk to them. What exactly do you want? Is there anything else that you haven't, you don't want? Because you know, after 5 years, if you're diabetic, only 50% lives. So, you know, we have to elicit the course of care for your patient. Most of the time, I have already discussed about intubation. Do you want ICU care and all the rest of it? A lot of patients don't want. And towards the end of life, if they are of course, they will come in under my institution. It's easy for me. Usually, I will step in and say, no, we're not going to intubate or ventilate the patient. Most of the time, I've already discussed with the patient and their family well beforehand. So I have never had any problems, patients or families disagreeing with the decision at the critical time. And the third skill, of course, you need to manage the basic symptoms lah. It's you know, whatever the nausea, the short of breath, and all the rest of it. So basically, it is again to impress on you that integrated ESKD care is a universal health coverage punya agenda, and conservative care is one of the it's number 8, so one of the principles. So it is not, it is still a treatment. Even, you know, delivering dialysis is still a treatment. So just to impress upon you, in Malaysia, that's why I showed you the palliative care. We're not too bad, but in transplant we are really bad. We are one of the lowest in the world having a transplant rate in the world. So we have to accept this. And we have to, if you read this article on the framework of how we establish integrated kidney care in low and middle income country, we have to accept that conservative care is actually part of a major part. Yeah, not HD, not PD, you know. We should talk more about transplant. Of course, we should delay progression. That should be our major bulk of the work. And we should realize that dialysis is temporary. If you don't get a lot kidney transplant, we can't really treat the patient, because transplant is the only treatment for end-stage kidney disease. So we need to talk a bit more about conservative care, yeah, or non-dialysis therapy. And how do you do it? This is, if you're interested, this is the core curriculum which was published last year, and it gives you symptoms and how do you treat each symptom, like shortness of breath, what you give, and nausea, and what you give, and so on. If you're interested, I can give you the full article, later. Okay, so the principles, how do you do kidney supportive care? You have to manage the symptoms. You have to be able to communicate. The part of the communication is prognosis sharing. You have to have an idea roughly. Of course, you cannot say you're going to die X number of months. You can't do that. We have to have a general prognosis, timeline. So like just now I mentioned, 50% of diabetic only live more than 5 years if you're on the start dialysis. So once you have that kind of rough prognosis, you could discuss, right? And these are the two things that's very important. I mentioned about advanced care planning just now. I always talk about this with my patients. They hardly end up getting intubated anywhere. When I'm talking about dialysis patients and those patients for non-dialysis therapy. And we always have to share their decision. We still have to share the decision, because like it or not, you're going to have to still see them when they become very ill. So usually what happens, a lot of people ask me, how do you do this? Usually I set goals, right? For example, 2 days ago, I saw a case. He's a very educated man. He's young, 30s, his creatinine is 900. He said he doesn't want us, which is fair, but he's not saying he won't, but he knows he will. It's just that he's not keen to talk about it yet. So we set a rough target. Say for example, I bargained with him, look, if your creatinine go up to 1,000 in 3 months time, I think that's time to already make your whatever, like your transplant, workup, and all the rest of it. So he agreed, right? So basically, I know you don't share the decision, but we have some sort of goal that we need to achieve together, right? And also very important that you have a team support. I'm very fortunate because IKN has a palliative care physician and very active department. So we do home visits for those patients going for non-dialysis therapy, because we want to make sure that they stay out of the hospital. So they have the nurses, we have a lot of medical officers, nurses, skilled nurses, and all the rest of it. And of course, we need to have all those, prevention, sort of maximizing quality of life, and management of CKD camp, for example, anemia, or the rest of it, even though they're not on dialysis. Right, and also end of life care. Usually, we give them bereavement support as well. When the patients die, we usually, text or call the family after that and make sure they are okay. And is there anything else we need to do or support them in any other way? Okay, so this is the a publication which showed roughly what primary nephrology team could do, and when we should refer to palliative care, proper subspecialist, because I think we all as nephrologists, we should be able to do basic stuff, symptom management, decision making. I told you, talk about social, spiritual, makan issues. Sometimes they just upset that they cannot makan this, makan that. But again, a lot of patients CKD end stage, people say you cannot makan this, makan that, makan that. I don't do that, because I feel that makan is the main, Malaysians love to makan, So usually I say, look, maybe we should, give them makan, whatever they want, but they won't be eating much anyway. So, everybody will be happy. So I don't have restrictions actually for these kind of patients. And of course, we need to know the basic medical management for conservative care. So when things become very difficult, this is when the specialty palliative care need to be involved in. Okay, so how do we do as a nephrologist? We're not very good at meeting the needs of our patients. We know that. Yeah, this is very clear. And we are also not very good at making shared decision, because I think a lot of times we forget about the patient. We don't integrate discussions, like just now, if patient tak nak dialysis, oh, off you go, I'll see you when I see you. You can't do that, right? We need to have a proper approach and making decision about starting, continuing, and stopping dialysis. And this has been published as well. And how do you actually approach shared decision making? You really need to have a good relationship between one another, and everybody is in the know. Just tell everything. But what you cannot tell them in Malaysia is actually how long more you have to live. That one memang orang marah. Please don't touch that. Don't try and answer that. Okay, so family caregiver is something that a lot of people forget as well. This is very important, because we need to collaborate with them, because they also symptoms a lot of physical, emotional, and social, economic sufferings as well. This is my publication because it's written by me, therefore I'm showing. This is my publication last year in JPSM, and this is a systematic review on Muslim patients. You would have thought that Muslim Islam kan kita terima kan, penyakit kita terima seadanya, we accept and all the rest of it. But actually our patients and families suffer quite a lot actually. Although they say kita mesti, hopeful, we have to be hopeful. Actually, they're feeling hopeless despite they wanting to be hopeful, So a lot of symptoms actually, we have to recognize that, and we have to accept this is a problem, and we have to help them in some sort of ways, whatever it is that we can. So firstly, we need to recognize this is an issue, right? And again, we as doctors, we only look at urea lah, creatinine lah, KTOV lah, potassium 8 lah, but they're not interested in all that. Our patients are more interested kalau tak boleh makan nasi lemak ke, tak boleh nak balik kampung ke, tak boleh whatever lah, So they're not interested in what you're interested. So really, you really have to find a halfway on trying to get them interested in something, and have some sort of shared decision making. It's not going to be easy, I know, but this can be done, I believe. Okay, I mentioned about advanced care planning. This is very important. It is recommended as best practice in end-stage kidney disease patients. So again, I hope that everybody, especially those patients that masuk ward, end-stage kidney disease, recurrent admissions, they are already very near end of life. So this is very challenging. You really have to take up this discussion fairly early lah. But again, suffering is everywhere. Right, everybody is suffering. Our patients is suffering not only with pain, everything, cancer ke, heart failure ke, COPD, CKD, dementia, they are suffering. A lot of symptoms already, but pain is only one of the symptoms. There are so many other symptoms here that we are not picking up. Sometimes we're not very good at treating. Sometimes the demented patient admitted to the ward just because of constipation, settle the constipation, everything will be fine, hopefully lah, but sometimes very little takes them to be happy, actually, to be honest. Again, not only patients suffering, not the family suffering, I think we as healthcare workers also suffering. That one is clear, right? Please, accept the issue, accept the fact that we are also suffering. And it's very, it's not easy as well. I understand everybody suffers, especially in this COVID era. You feel that you're not doing enough for the patients, but this is a recognized entity. And sometimes when you have a lot of conflict in clinical decision making, even with your colleagues, sometimes you nak menjerit, orang ni tak faham, orang ni nak conservative care, orang ni nak dialysis, But again, maybe they have the reasons why they want that. Just step back, pause and reflect and explore each other's position. And then with your colleagues, not only with your patients and families, with your colleagues, always have a step back, discuss and develop a shared plan. This is very important as well to address our issues. So I always show this. I will always say, when you see your patients, don't just say how are you, not just ask. Don't just ask what is the matter with you, but simply ask what matters to you. That's very important. Yeah, something is a lot of us forget to do. Okay, this is, I'm not going to ask you to look at the details of it, but this is my integrative renal palliative care framework, which is chair. But one of the important part of developing renal palliative care within the structure of renal services is actually having some sort of shared decision making here. So we need to have a shared decision. We need to have some sort of way that we can actually discuss dialysis options with them. So this is another recently accepted by Kementerian Kesihatan Malaysia. Not only it's not draft, it's already been accepted and probably circulated fairly soon. And pre-dialysis education program is something that we're going to do. Hopefully we can, I'm also the chairperson for PDEP, we call it, nationwide. And I'm looking for people to write inside there to develop the structure so that everybody has an access to it, and everybody will be able to, the public will be able to know what is best for them, and we can share their decision, and they know what or how to decide. Yeah, and this is one of the first steps where we have our own website through My Society, of course, met with my, where we have a website that all the public can go there, and as the one of the main admin, they can also ask questions. Of course, general questions we will answer. There's three patients and 4 nephrologists. We will be answering actively there. So if you could potentially also let your patients know about this website, they can go in, right? Kalau you macam, this is very simple in clinic, very difficult question, they can go in and ask us. One of us will answer them, inshallah. Yeah. So again, I think this is my last slide. I hope what I've tried to impress here, I think number 1 is actually non-dialysis, or we call it conservative care, and withdrawal of dialysis are options for end-stage kidney disease patients. And the integration of palliative care and nephrology is the way forward. That's what I'm working towards, hopefully. And kidney supportive care fits the description of integration, where we incorporate all the principles of palliative care inside the normal day-to-day nephrology practices and address the symptoms accordingly. And all nephrologists should be able to practice some sort of primary palliative care, and hopefully all the general physicians as well, and all of you out there. And we should be able to have some sort of routine symptom assessment and make some sort of decision together with the patient, and be able to screen non-pain symptoms. And sometimes sebab anak dia tak balik kampung je pun dia dah sedih, and because of that dia masuk chest pain, for example. I'm just giving you an example. And we need to be able to manage conservative care fairly well. And there is a huge pre-existing knowledge gap addressing CKD patients, and we actually don't know what's the best care for us in Malaysia, because Malaysia is unique, and we need to know what our population wants. When I was in the UK in the class, and everybody was so impressed with Malaysia, bizarrely, and they think that we're really doing a good job. Yeah, and they really want to learn from us, but the thing is, we don't really do this. We don't really research our own population. I think we should. That's one of my priorities in the near future as well. So this is my last slide. Thank you to this is my colleagues in King's College, both from South America, and thankfully I got distinction from the masters. And this is the pioneers of initially the Facebook, and they are the ones who actually also attended a palliative supportive care, renal supportive care course in London with me, Dr Fadlina from UPM, Serdang, Dr Lily, I think most of you know if you're in Negeri Sembilan, and Dr Suriati is actually a consultant nephrologist in Selayang now. And the reason why I did palliative care is actually this girl, she is my niece. She was staying with my mom. My mom is on dialysis for 6 years, and she came up to me, this is about 3 years ago. She said, no doctors will ever understand what Nene is going through. She is suffering. I think for a 9-year-old to come up to a 10 years, I think I was already a nephrologist for 15 years, to tell me this, I think that was really something that hit me in my heart. And I think because of that, I realized that, I need to know a lot more about my patients. I think with that, I'm going to stop there and back to Iskandar, and I'm more than happy to answer any questions from the floor. Thank you very much for listening.
Okay, thank you very much, Dr. Rafidah, for the pro bono presentation. It's very well presented for something which is free. So I hope it's free.
Free Tak boleh charge ke apa?
So I hope my MOs and the other participants will be really understand the presentation very well. And okay, now actually we have 2 questions from Azlan. Okay, actually about the clinical, he already typed the first question. If a patient who already decided for renal palliative, then transplanted to ED, then the family keen for HD. This is very common. How you deal with it?
Okay, so there are multi-pronged answers to that. Most of the time, it's either the first decision was not right. Basically, remember I said just now, whether it's conservative care or they tak nak until very late. So in my counselling, pre-dialysis counselling, when they reach about GFR 10, I will always ask that question. I will always ask, is it because you just don't want, or is it because you just want to delay until it's very late? So this entity need to be separated, and that's number one. Number two, you really need to get the family involved in the discussion, identify the main person who actually is the decision maker. So once you get that sorted out, of course, if it's non-dialysis, I showed you in my slide, even for somebody who's proponent towards non-dialysis therapy, my percent of dialysis, my patients actually chose and I accepted the choice is only 4 to 5% sahaja. So these kind of patients, if they come in at the door, usually I have again another counselling, because so most of the time if I do the counselling, it's not difficult for me because I will remind the family, look, this is what your mother decided, you have to respect her decision. So most of the time I have no problems, but again, this take months, this take years of experience and take hours of counselling. So if it's in your situation, although the patient says don't want dialysis, but the family wants dialysis, the family still has the legal right at that time. Sorry, if the patient cannot make decision, the family still has the legal right. But if the patient can still make the decision, you still have to ask the patient. Granted, the patient might be uremic. The family might be saying, "Yo, my mother not going to be able to make a decision then." But I suggest put everybody in the same room and ask again, what do you want? It is a very long answer to a very short question, but it's not something easy for you to go through. Even I have problems, but again, I have no problems if I decided a lot earlier. So I hope that slightly answers the question. It's easier said than done. I know it's very practical, but you have to accept Malaysian patients are like that.
Thank you, Dr. Rafidah. So the second question for Azlan is how you prognosticate the survival rate in patient who is keen for the renal palliative. Sometimes they're asking about how long they can survive. We are always having problem to give the numbers to them, Dr. Rafidah.
Okay, thank you. There is some sort of I don't believe in that ada prognostic survival punya. I got the apps. I think you Google it out, especially for the elderly. You key in numbers, key in creatinine, there is X number of. I don't believe in numbers. I'm not a number believer. So I also hope that everybody will not give any numbers, because again, they can die anytime. With acute MI, for example, I cannot predict that. What generally the outcome, if you have a 75-year-old with comorbid, tak kira lah hypertension ke diabetes ke apa semua, whether you dialyze or not, roughly the survival is about the same. But those ones who did not go for dialysis, they will have a better quality of life. So again, this has to be individualized. Nowhere we can give numbers. I think as well as that, we should not play with numbers, because nanti, say for example, you give 6 months, nanti setahun lagi masih hidup lagi, dia balik kata ha. You see, you give 6 months. See, I dah hidup 12 tahun. Setahun. So I think be very careful with the numbers, because I showed you the trajectory of CKD stage 5. It can be all sorts of trajectory. It really depends on case-to-case basis. So I hope that answers the question as well.
Okay. Thank you, Azlan, for the question. I have one question. This is normal to happen in each time. What happened is some patient with end-stage renal failure, example, for those who already on permanent catheter. So now they came in with CRBSI, very severe sepsis. So the family and the patient don't want any active discharge. Should we continue the dialysis, or we can stop from there onwards to stop the dialysis?
Okay, so again, it depends on, firstly, if somebody, to me lah, for a nephrologist, if somebody is already on cuff catheter, I will always have some sort of advanced care planning. Like, for example, they have no vascular access, they have no option of PD, you're basically stuck lah, that if that is the last. So the only other pathway going to happen is CRBSI, especially if you have a staph aureus CRBSI, rasa nak susah gila. So most of the time, if it shock, very easy lah, you just remove and withdraw. But this is when the part yang neither here nor there. So macam you still treat with antibiotic, you're not too bad, you still can go for dialysis, and that becomes very difficult. But the thing is, these patients, if you remove the catheter, very difficult to put it back in, because there are very limited options anyway. So I have had a variety of patients. So as I mentioned just now, kalau shock, very simple, remove and withdraw. But those ones who actually have symptoms, I would just treat with antibiotics, and if they can't, we have to discuss. We have some time lah for you to discuss, about 2 or 3 weeks to discuss about what exactly do you want. Do you want to withdraw, or do you don't want? If you don't want to withdraw, if they're still symptomatic, sometimes what I do is I just give some macam PCM pre-dialysis. Those are what we call it palliative anyway. So it's very difficult to withdraw. Remember in Malaysia, we are in Malaysia. Kalau dekat Masaleh tu very simple, they just withdraw, right? But we are in Malaysia, you have, as I say lah, 3 wife, 30 anak, very difficult. They got their own mind. Orang kampung, orang sebelah, they got their own mind, and kita kata apa? Usaha, so in our religion pula ada cakap benda macam usaha. But usaha tu is actually, kalau benda tu dah futile, we should stop already, actually, to be honest. So there are variety lah, macam I cakap. So usually I will not remove, reinsert. I will not repeat, tukar, buang, tukar. I will just, at one point, if they have recurrent CRBSI, eventually they become very ill. Eventually lah. When that happens, you probably withdraw. So that would be my how I deal with but having had discussed a lot earlier before they start dialysis, long-term dialysis on cuff catheter, because that's already last resort. So again, it's individualized. So not easy to, it's easy to say lah. Practicality is very difficult, isn't it?
Yes, it's true, Dr. Rafidah. So if there is no more question, I would like to thank you, Dr. Rafidah, for spending the time with us. Actually, it's a very good presentation and a very complete presentation for a free presentation. I would really to thank you very much, Dr. Rafidah, for helping me. Actually, for all of you, actually, I just told Dr. Rafidah previously, I think last week I told her that actually I have a problem in knowing about palliative dialysis. So that's why really she just offers herself. She is the one offering herself. So thank you very much, Dr. Rafidah.
I nak beritahu you pasal palliative dialysis lagi. Boleh tak?
Yeah.
Okay,
Boleh, boleh.
sorry, I cut you. So basically, I give you an example. Say for example, you have an advanced cancer patient, right? And the cancer is actually inside the urinary tract and lower abdomen, and it's already spread. So basically, your obstruction you cannot do anything about. So basically, the patient will need dialysis to live for a few more weeks. I would actually offer palliative hemodialysis then. Means that they still live for a few weeks. Actually, some of the patients got better as well, before they die. So again, this is case to case basis. Like we can't just generalize. You give this for everybody. So like recently, I had a 36-year-old who's got advanced CA colon, which is now obstructing the urinary tract. They just whatever they did, they just can't reverse it. So I think so. Again, this is case to case basis. So there is also another entity which is called time trial dialysis. So basically, you start dialysis, you're not sure of the benefit. This is when the family duk gaduh A, B, C, gaduh kan. Dia tak nak lah, ini nak lah, okay tak apa. So usually what I said, we do a time trial dialysis, maybe 2 weeks, 3 weeks, 1 month, we revisit. If the patient doesn't do well on dialysis, whatever lah, we will withdraw. So but bila you withdraw, you tak boleh just discharge, which is good for me because I have a very good palliative care team. We also visit the patients at home. When we actually withdraw dialysis, we just withdrew 2 days ago. On somebody who had no more vascular access, 8 years on dialysis, CRBSI, and we visit at home. So the family felt that's a lot better. The family felt secure. So this is also another option that we need to think about lah in a day to day. This is more fun. I would say medicine is more fun this way. Yeah. Thanks again for inviting, Iskandar. I think I invited myself, right?
Yes, Doctor. But thank you very much, Doctor, for the very good explanation. Maybe later on we can have another session. Maybe later on. But by the way, for all the participants, by next week Sunday, Dr. Rafidah also will be talking and met with my CME from 8:30 to 9:30 regarding this renal failure. How to diagnose renal failure. I hope all of you can actually join us, and because this current session we already upgraded our Zoom meeting to 500 participants. Hopefully it is enough, and also we also try to do a streaming through Facebook also. So with that, I would like to really thank you, Dr. Rafidah, and thank you for the others for joining us, and we will update you again if we have another session of Zoom meeting later on. Thank you very much. Assalamualaikum.
Salam.